Incorporated for sponsoring this event. BioLens is a custom contact lens company that manufactures scleral lenses, orthokeratology, and soft contact lenses as well. Over the next couple of days, we'll be talking about the BioLens orthokeratology lenses and what BioLens has for some of the attendees of this webinar series in terms of incorporating orthokeratology in your practice in Africa, and also how that can help improve your practice in terms of patient management and also revenue as well. All right, so today's gist, we'll be talking about two topics that are very important when it comes to myopia management and are often not given their due recognition. As a clinical practitioner involved in myopia management, and as many of us who are involved in myopia management know, that while we often would prescribe maybe spectacles or contact lenses or low-dose atropine, there is also the mental health impact that myopia has, and it's something we often don't talk about as much. Also, sometimes when you present myopia management to patients or parents, because most times we see progressive myopia in children, but in few cases adults. But a lot of times these children, they don't make these decisions for themselves. The parents make these decisions, and it's important to carry them along. And there are ways in which we can explain these strategies to them to make them understand the condition and onboard them in the myopia management as well. So to discuss these two topics today, we have Dr. Levi Oswagu and Kevin Chan. But we'll be starting with the first presentation with Dr. Oswagu Levi. He's a senior lecturer and academic lead at the Rural Health School of Medicine, Bathurst Rural Clinical School in Western Sydney, Australia. He's also one of the founders of the Center for Eye and Public Health Initiative, CEPHI, that is involved in several landmark research projects in Africa, including myopia as well. So Dr. Oswagu Levi, you can start off. I'll make you co-host and you can share your screen. So you should be able to share your screen now.
Yeah, thank you, Obi. Yep, that's working now. Yeah, thanks for having me, and thank you for making this series. I think last year was epic of this, and we saw a lot of people from across the globe joining this group. And good, I think that this year this has also taken the shape and now focusing on myopia. So it's really good to see how we in Africa can start to turn things around, because we seem to be quite behind in so many things in research. Like as introduced, my name is Dr. Levi Oswagu, and I work in Western Sydney University in Sydney here in Australia. So I think mental health and myopia in children and young adults has been something that's quite a great area for us in Africa. You know, we seem to be coming late to the party, but I think increasingly there's been a lot of focus on treating people with myopia. Is not just a clinical thing of giving spectacles and contact lenses. There are other things that as well hinder people from getting the sort of progress that we expect them to have. So that brings us to other spaces of how do we holistically care for individuals when they attend our clinics, and not just focus on the spectacle lenses that will bring along to them. So I'll try to see how we get this going, but I just want to get us thinking in this direction. Assuming you're this individual, you imagine that's your experience every day. You're always indecisive, but now you're not even sure about the future. Just like myopia, 1 minute you see the future clearly.
I think we lost Dr. Levi temporarily. We'll just give him a minute to sort himself out. I'll just contact him.
You're good now?
Yes, you can carry on now.
No worries. Okay. I just share my screen. So, can you see my screen now?
Yes, we can.
All right. So I'm just trying to really get us into that mode of what this is all about from the patient perspective. And it's always true when we say your eyes are an extension of your brain. That's a fact because the retina is actually made of neural tissues, and it's about the only part of the central nervous system that you can see directly from the outside. The reason when you do fundoscopy, you're able to see that and use those to make interpretations of what's happening. So when we say the eyes are the window to the soul, science actually thinks that that's true because it's more like having a skylight into the brains. You actually seeing into somebody's soul when you look through the eyes. And that's really what makes the eyes an important part for all of us. And the reason our profession is really there to us as well. This study from the Brian Hoding group in 2016 had been one of the landmark studies when we talk about myopia. It's projected that by 2050, about half of the world population will experience myopia. So that's a big deal. That's a big number if you look at the number of people who are affected in this, who will be affected by 2050. This has changed from 2000 and the projection took us to 2050. So that really sets us the pace to, we really need to do something. And many of these people will be part of the people we'll see in our clinics that come to your clinics in sub-Saharan Africa, your clinics in Nigeria as well. And about 10% of that population will have high myopia. And with high myopia comes all the issues with severe visual impairment, blindness, and other things that come with the mental health as well. So this is really a topic that we have to be very conscious of. So this rising concern of the global increase in myopia prevalence is really something that is real. The reason myopia is no more seen as a disease. It's an epidemic now. So we really need to think about it just like we thought about COVID during the pandemic, because the world is going to change quite dramatically in our faces. COVID did not make things easier. It actually made it worse. So we think this might triple the numbers that he had projected for in 2016. And they also showed that the prevalence of myopia is not only changing in the demographic. Initially, it used to be those between ages of 10 and 39. But the current prevalence projection that we see here with the dark line here tells you that it cuts across ages, even between 10 years up until 75. So across all ages, this prevalence would increase. So that puts increased pressure in us, the clinicians. It also means that we'll have so many people coming being very worried that their future isn't looking bright. So there's really a case here for optometrists to take the lead and think about myopia as a holistic approach and how we can help the patients as well. So the mental health trends in young people is not looking any different.
Yeah, we can still see you, Levi, but we can't hear you. Your mic is muted now, and we can't see your screen. You need to reshare. Your mic is still on mute, Levi. We can't hear you.
Yeah, can you hear me now?
Yeah, now we can hear you.
All right, I'll just quickly switch this to my mobile internet. I'm not sure what the house one is doing here.
All right.
Just so I don't get this video coming. So just give me a sec. I will quickly.
Yeah, we can see you.
Awesome. Yeah. So I should be good now.
Yeah.
Not really sure why the.
Perfect.
That's good. Sorry, I'm home, so hopefully. Yeah, so just to continue with that, now the changes in the mental health prevalence uh, across years from 2000 to 2020 is also showing us that things will worsen in the near future. No, and this is linked to the academic pressure, increased screen time for our young people, the social isolation that we face coming out of COVID, still looking quite bad for so many populations, and the chronic health conditions that keep increasing in prevalence as well, just like depression, anxiety, stress. And we've seen that in one systematic review and meta-analysis that was conducted, they noticed that about 13% of adolescents across the world have mental health condition, either depression or anxiety. And about 1 in 5 of adolescents may experience a mental health disorder in a lifetime. So this really puts this as something of interest to many of us. And recently, we've started looking at those as well in the patient that we see in clinic, mostly those with myopia. There's been an established link between myopia and mental health. From a longitudinal study from East Asia and Europe, they've reinforced this idea that myopia can lead to reduced self-esteem, social withdrawal, and there's also increased pressure from studies and academic performance of children who have myopia. So we've seen that mental health issues may promote behaviors like sitting at home watching TV all through, not being able to go outside, fear of stigma, people just focus indoors. All these practices worsen myopia. The mental health issues also affect their motivation of your clients, your patients to seek care, to follow treatment. Some wear spectacles and they're being mocked around in schools. And for that reason, they just don't wear them. Some are afraid of attending follow-up appointments, thinking you're going to increase their lens powers, and the lens will get thicker from the way they sit. And often they refuse to engage in rehabilitation. There's also been studies that show that depression can influence the patient's perception of their visual difficulties. And that then leads to exaggerated perceived limitations of their capabilities. It will also impact the ability to adapt to new prescriptions or even low vision aids. So these issues do go along in the minds of people that we care for. And oftentimes we're not looking at those conditions. We'll just think that, oh, why is this not changing? Why are we not having any progress? We're not looking at the person as an individual that will be dealing with so many other things within themselves as to how myopia has impacted their mental health. So these observations from numerous studies now are really letting us to consider that we need to start developing strategies to control myopia properly. It is important to then focus on the mental health of the children and adolescents that come to our clinic. Let's start thinking about that from the first day we're prescribing glasses. Can we look at other ways of intervening and not just giving them glasses and telling them, see you later? There are too many other things that we have to start thinking about now to see the individual as a full person, not just somebody with myopia alone. Now, honing this down to Nigeria, there's been a study by Onyebueke and colleagues where they investigated depression among patients with various degrees of visual impairment who attended an ophthalmology practice in Enugu. In that study, they found that about half of the individuals they looked at who have visual impairment reported major depressive disorder. This was mostly those who had severe visual impairment or legal blindness, between moderate to severe, and those who were legally blind. They also found that when they used the vision-related health status to quality of life index, they found that the quality of life was negatively related to depression. So meaning that in these areas, there's a decline in the areas of vision, of general vision, ocular pain, increased depression. So if you have higher depression, your general vision depreciates, your ocular pain increases, and the mental health issues increase as well. So this has become an important area for us clinicians to start thinking about. We also did a study somewhere in Calabar, Cross River State, in 2023, with a group of ophthalmologists and some group members in Cefi. And here we enrolled only those with high myopia. We define that as myopia of -5 or above. We found that in this clinic, out of the 100 people we examined, we did this both, we had interview side of the study, so it was a mixed method study. But in this study, we reported only the quantitative data. We found that 1 in 6 people with high myopia had mild to moderate depression. And 1 in every 9 person reported clinically relevant depression. These are people who came to the clinic, just normal consultation, they were recruited. And when we find that they had high myopia, we administered the questionnaire and also did some interviews. So this is really a case that we all experience in our clinics. We just haven't paid attention to these things. As you're listening to this, you may be thinking of those patients that you're monitoring today, you're looking at. Have we considered what sort of mental health conditions they may be going through? Those glasses that they're not comfortable with, they come each time complaining, we're worried, why is this not helping us? Why are you not doing well in this? Have we looked at the other side of life? How can we support them better, not just by prescribing glasses? Now, with that same point, even myopia as well had significant effects on the quality of life measures of these participants across all domains. As their physical health decreases, their rate of depression increases. So every domain of quality of life was related to their mental health state. And this is only within those with myopia. So it affects the quality of life. It also increases their rate of depression. We also found that when we did our regression analysis, that those who were younger were most affected between 16 and 29 years. And mostly women had higher rate of depression than the men. This also aligns with other population data showing that depression affects more women than men. Not only in Africa, there have been other studies in Asia and Australia that have shown the same thing as well. So the factors we know that actually mediate this relationship between myopia and mental health are mostly psychosocial factors. There's been experience of bullying, self-image concern from the use of glasses by children and adolescents, pressure from academic performance. There's also behavioral factors, like I mentioned earlier, sedentary lifestyle, excessive use of screen, sleep disruption. Unfortunately, all this post-COVID has not been the best that we experienced in recent times. So that has really carried on with the lifestyle that was disrupted during COVID. We seem to have continued that practice in one way or the other. And that hasn't helped the prevalence of both myopia and mental health. Now, what's the role of optometrists here? And remember, we're often the first people that these individuals come in contact with. As a primary health provider that we have the opportunity to see these people firsthand. Even before they meet their GPs or their doctors, they may have come to you. So we're in a position to recognize the signs of mental health problems much earlier, doing our eye exams. Have we thought of offering our patients some education on the importance of outdoor tasks, how to manage screen time? How have you involved holistic care in the approach to myopia management? So I call on people to look beyond refraction today. It's not all about the -6 and -5 we prescribe to them. Yeah, that improves vision. But beyond vision improvement, what's happening to their entire health? Can we integrate mental health screening tools? Simple tools like the DAS-21, PHQ-9, the GAD-7 for anxiety will be easy screening tools that will say, yes, okay, I can refer this person to someone to be able to support me in this management? Are we paying attention to those nonverbal cues or expressions of negative feelings that patients tell us, oh, I don't really feel good about this when I go to school? Are we looking at those complaints that shows they're isolated, they're frustrated with their vision not improving the way we want? We also need to be aware of the demographics that have been shown to be at higher risk. Women, adults, those who are not employed, and those with more severe visual impairments. I think there's need to have standardized referral pathways for participants who come to us with myopia, mostly those with high myopia. Can we identify those we can collaborate with, the GPs, the school counselors, and the psychologists? Because they are part of that holistic care that we promote. And that's the way medicine is moving now across the board. There's need to incorporate other health practitioners in the treatment that we offer. We also play a preventive and public health role as eye care practitioners. The low vision rehabilitation we refer, we provide to these people is a key component. It helps the patient to maximize their remaining vision and adapt to those limitations that they will ordinarily not be able to do without their glasses or visual aids. Studies have also shown there's increasing need for social and emotional support from families, from healthcare facilities and social groups. People who wear spectacles actually need people around them to be educated as to why they're using it and how that will help them going forward. There's always this notion that when you wear glasses, your eyes correct. And people see correction as a different thing. They don't see correction like what we optometrists interpret as correction, making it easier for you to see what you're not able to see before. It doesn't mean that the next 2-3 years they may drop their glasses. Some people will continue wearing this. The power may increase. They also need to understand why that will happen. So that support can come from the family and people around them. We need to provide an environment that is supportive in our clinic. That's actually the first step that they can open up to us on how they feel about their correction, how they feel about wearing it, what do they experience, what do the society think about them, how do they feel when they go out, how are they being perceived. They can tell you those stories. So there's need for optometrists to be involved in advocating for policies as well that promote early detection, rehabilitation, and social integration of those with visual impairments. We cannot stop talking about outdoors because outdoors seem to have gone out of the blues for us. Initially, when we were growing up, we used to play out. There were no screens to even watch. TVs were rarely found in many homes. So we played all our games, soccer, in outdoor. We are always outdoor most times after school days. You could see why myopia is increasing more so in sub-Saharan Africa, where we thought it wasn't the case before. So families need to be educated on how to balance their screen habits with the kids. There should be regular vision and mental health checkups should be incorporated as part of our follow-up and routine checks as well. So the idea that we're part of a broader healthcare team is important. We need to recognize that there's a limited scope of our practice. So other healthcare practitioners play a significant role, even the patient that we care for. We can share care. When people exhibit signs of significant depression and anxiety, who do we refer them to? Are we collaborating with those mental health practitioners around our space? I said it before, we need to establish further pathways to professionals that can support us in this management. A simple conversation and offering a referral can be a lifeline. For a patient struggling with the emotional burden of vision loss, it's not easy to think that your vision will be lost with all your dreams, shattered. That takes an emotional toll on people, on your patients. So the simple glasses that we give may not be the solution to what they are going through. People going through myopia management should have a stable mental health if that management has to be effective. It's the way we see the patient as an individual. And I wanted to just ask us this simple case. You had Sarah, a 25-year-old female patient, who presents for your routine eye examination in your clinic. Refraction reveals that Sarah has high myopia -7 diopters. Uncorrected, her VA is significantly impaired and impacts her daily task. During history, Sarah mentioned recently leaving her job because she found it too difficult to perform her tasks accurately. She feels isolated from friends who are busy building careers or socializing in ways she finds challenging now. She expresses frustration, worries about being a burden on her family, echoing financial dependency, and concerns. She avoids social gatherings. She is hesitant about her new thicker glasses. She did mention that she had difficulty sleeping and loses interest in all her hobbies, which she used to enjoy previously. How would you, the optometrist, proceed with this? Do you think prescribing a -7 spectacle solves these problems for Sarah? Oh yeah, she will be seeing better. Each time she comes, there's an increase of, say, 1 diopter or 0.5 diopter. Does that really solve Sarah's concern? Would Sarah be able to express this to you as an optometrist in the clinic? They will provide a platform where this discussion happens. So beyond prescription alone, we need to acknowledge that Sarah is struggling. There's need to explore how that reduction in vision is impacting her areas of life, social activity that she performs. Can we consider a referral to a counselor that can help improve her quality of life and her ability to cope even with the new spectacles? This is a typical case of most people you see in our clinics with high myopia, really. They go through this, but they may not have had time to tell you. So myopia and mental health are interconnected challenges. They have a bidirectional relationship. And in people with myopia, quality of life is also very much affected. Studies have shown that across the board. And we did in our Nigerian study as well. So the severity of visual impairment correlates with poorer quality of life. So the higher your visual impairment, the more reduced your quality of life will be. So we as optometrists have a key position here to dictate this science early and support a holistic care of all patients that come to us. I call on us to be proactive, have to collaborate with other healthcare practitioners. You need to show compassion to the patients that we are treating because the emotional burden of myopia is a huge thing. To conclude this, I just want to pause and say we need to address the burden of myopia and visual impairments through a holistic lens. Recognize that there's a link between myopia and mental health. Actively listen to our patients. Be prepared to offer support and referrals. We play a vital role in improving not just their vision, but the overall well-being and ability for them to fulfill their life goals. We need to invest in the mental health of our participants. Because when we invest in it, we're giving them the ability to manage the eye health effectively. Some of those corrections may work better if we look at the individual as somebody who has other issues that the glasses we prescribe may be predisposing them to. Can we start talking about that in our practices? And I know while we do that, our practice will change dramatically. Just want to thank everyone for your time listening. I'm happy to welcome questions. I'll be flying out to Sydney from Brisbane in about 1 hour. I just thought, and Chan, thanks for allowing me to go first. I know Chan was supposed to be earlier before my talk, but I'm happy to welcome questions and I'll be here for the next 30 minutes before I head out for the airport. Yeah, thank you.
All right, thank you very much, Dr. Swagu. So we'll just give, say, the next 5-10 minutes for questions for Dr. Swagu, but that was a very lovely presentation. If you have questions, leave them in the chat section, and then we'll take them after the 10 minutes timeline. If you have further questions, you can send them via email and we'll take them so we can have Dr. Chan go in. So the first question, I'll just read that out. So do you think quality of life will change as per geographical location from the amount of refractive error, Dr. Levi?
Yeah, Obi, thank you. And I think I didn't show the study I showed you that we published also showed that location was a significant factor in how people's quality of life depend on their myopia. And I think it's still going to be the same. So the quality of life of the patient when they come to you and the quality of life of the patient during their myopia management will reduce drastically if we don't look at that from a holistic point of view. So where they start from and where they're going to be doing your management is largely dependent on how you approach the mental health aspect of this. Can we manage that concurrently as we manage their myopia? Is there a counselor involved? Can we get a psychologist to look at what other aspect of their life do they think they lack in? Like I showed you, the social lifestyle of Sarah was drastically reduced. Sarah didn't want to go out anymore. She didn't want to wear her glasses. She stayed indoors, and that sort of reduces her quality of life. So irrespective of the location, it will be a similar outcome as shown in few studies that if we don't look at that from a holistic point of view, we'll have depreciation in every domain of the quality of life without looking at the mental health space that these individuals are in.
All right, thank you very much for that answer. And I'll follow that up with a question. Now, I mean, from the presentation and from papers you've presented, it's established that there is the need to incorporate mental health in terms of myopia management and creating that room, an open room for us to have that discussion. Now, as clinicians, we often will deal with what we can detect or what we can diagnose. So yes, we may not be able to diagnose a mental health condition, but you did mention some questionnaires that can be used to screen these patients. So can you throw more light on those questionnaires? And are these questionnaires validated for checking children in a clinical setting? And would you also recommend that as people involved in myopia management, and if maybe we do a PHQ-9 questionnaire or something and we pick up some issues, for example, would you recommend that you have maybe the contact of a psychologist to put on your referral team so you can have some relationship with them? What's your take?
Yeah, thank you, Obi. I think that debate, whether any of the mental health tools has been validated in kids, has always been there. But either of those tools are validated tools in various populations, and they are just screeners. You actually are not diagnosing mental health. You are identifying those who are more likely to have clinically relevant mental health issues. And there's a score line for that. There's a score at which each of the tools gives you a guideline for scoring. If somebody gets, for instance, 6 over the number of total, it tells you from that 6 and above, you have to consider this person may have depression. For instance, using the PHQ-9, the DAS-21, so has depression, anxiety, and stress. So each of those sections have got questions that identify each of the mental health issues. And once that person is within that threshold, it becomes a candidate that you can think about referral. If their threshold is lower, then the screening just tells you that they are not really those you'll be considering to be of a high risk level. So if you use any of those tools, you're able to say, oh, okay, Mr. A has scored this number, and this is telling me that there might be issues of depression going on here. Can I contact a psychologist for them? There's nothing wrong with just putting that referral to, and that actually means that you as an optometrist is looking at this person as a person, not just myopia, because myopia maybe they're presenting signs from the symptom. The thing they narrated to you, but there are other things going on with the person that could hinder your treatment, that could hinder the effectivity of the management that you've provided. So I think looking at that actually helps you improve your clinical practice and shows people that you understand what's happening in this modern day and age. In Australia, it's become a practice to refer people to psychologists. In fact, glaucoma is actually one of the bigger issues as well. Once you have glaucoma, diabetic retinopathy, quality of life drops very quickly. The same with their mental health state. So there's been that incorporation in clinics of a social worker being part of the management team. Some clinics and hospitals have them in clinic. So they can come in and join in that discussion as to this, wearing these glasses will help you in this space. It even help you to provide you good quality of life. If you're seeing better, you can do the things you love doing. So they are not affected by the stigma of wearing glasses, by the bullying that goes on in schools. Those things help them to progress and also comply with your treatment regimen. So there's really need to have a psychologist at hand that we can refer to.
Thank you very much for that. And I think one of the participants actually echoes some of the last sentiments you raised. So it says beautiful presentation. I could relate with mental health aspect of myopia, but I think it's even worse when there is glaucoma. And you also mentioned other complications as well. So I mean that's something important. If you wouldn't mind, if in the chat section, maybe for participants, could you just list some of the questionnaires that they could use in the clinics to evaluate their patients. And
Yeah.
while you're doing that, I would just take the last question and then we go on to Dr. Chan's presentation. Um, this is for schools, there's always a college counselor in every school. It's advisable to liaise with the counselor while managing myopia or eye condition of children as there are many factors affecting quality of life. I think that's a very good point. That's something that I think is underutilized. I remember in primary or secondary schools, you have a guidance counselor, at least in Nigeria. And oftentimes you often wonder what these individuals do because we hardly ever went to them. So, I mean, engaging with them in terms of managing patients or individuals with myopia, I think that would be important.
I
The
think
last,
I think just to add to that, I guess the why this is an important topic for us in Africa is the mental health space is not talked about. Nobody wants to mention that. Even the parents want to run away from you telling them there's a mental health component here. They tend to think there's a witch. Now, are you telling me somebody is bringing witch is a witch to my child? Is my child going to kill all of us? So sometimes we as practitioners can bring that discussion to limelight and reduce that cultural stigma that we carry. If they are hearing it from you, they are more likely to believe that this is real. This is a condition. It's not a disease that somebody inflicts on the child. It's a condition that they can manage. It's a chronic illness. The more like you have diabetes, you have glaucoma. Mental health is a chronic condition. If not handled properly, then it could escalate. So if the parents are hearing it from us practitioners, we are helping the society to come to terms that mental health isn't any devilish act. It's not something caused from demons. It's real, and we're here fixing it. COVID has made this very clear that people are going through tough times, and those tough times reveal in the way they accept your treatment, it reveals in the way they comply with what you're telling them. So hearing it from us here makes a difference.
Thank you very much for that. And something you mentioned about COVID and how it impacted them, and it reminded me of an article, an opinion piece I had written for iAfrica Media podcast, and we were talking about how we often, I mean, some studies will look at mental health and myopia in individuals with myopia, but we often don't talk about how it may affect the parents because for chronic conditions, parents sometimes feel guilt, shame, and things like that. And that rightly leads to Dr. Kevin Chan's lecture. But from your perspective, researching mental health in myopia, would you say, what would you quickly, what would you recommend that we look out for? What are those signs we should look out for in parents who may exhibit signs of mental health issues due to the condition their child is facing?
Yeah, Obi, I think that's a very good question. In that study I showed you was a mixed method study. And the second part of that study, we interviewed the parents, the carers, and the participants. And what the parents are telling us is the same thing. They're telling us that they don't want their child to start wearing glasses as early as 5, 6 years. They think if they start wearing glasses, it means that they didn't do their job well. They feel guilty. The mom actually said, look, I feel it was my fault. Something happened during my pregnancy that has caused this child to bear this condition. They don't see this as something that could be genetic. So there's this self-pity themselves that they carry. So I think for us as practitioners, that education is important. That will start talking to them about why myopia may develop. They understand that this is not their fault and the child can get through this. So that stigma is huge. I guess for parents as well, it's also good to bring them into that care of management. I often see people, when adults come to the clinic, they keep the parents outdoor, they take the child in, refer, give glasses. That's the end of story. But the parents do not understand why you're giving the spectacles. Their education is it has to incorporate the family network. No, why are we giving the glasses to this individual? Then you're able to explain to them, and they can help to enforce and encourage the child to wear the glasses. So there's really that co-education that happens between parents and child, even while you as a practitioner is recommending those corrections. It's important. Else the compliance will be quite low.
Thank you very much for that. So I think I mean we're very grateful for your time. I guess you're still here for maybe 10 minutes more, but
I'll be here for
take
another
Dr.
20 minutes.
Kevin now. All
Yeah.
right, so